Welcome to Grand Rounds for Rehabilitation and Movement Sciences for May of 2026. This month we have two presenters. One on Dr. Purinton is going to talk to us about prognosis following gluteal tendon repair, and Dr. White will talk to us about implementing reflective-based practice. Dr. Purinton earned her Doctor of Physical Therapy and Master of Clinical Health Science degrees from University of Delaware. She is currently pursuing orthopedic physical therapy training through St. Luke's University Health Network's Orthopedic Physical Therapy Residency Program. With a strong passion for physical activity, recreational sports, and coaching, Dr. Purinton brings energy and purpose to her clinical practice. She is dedicated to building meaningful therapeutic relationships and delivering patient-centered care tailored to each individual's unique goals. Dr. White earned his Doctor of Physical Therapy degree from DeSales University, where he completed his undergraduate studies as well in sport, exercise, and physiology. He is an orthopedic physical therapy resident as well at the St. Luke's University Health Network. Grounded in a strong foundation of exercise physiology, Dr. White's clinical interests focus on physical stress theory, motor learning, and facilitating patient self-empowerment. Dr. White currently practices at the Physical Therapy at St. Luke's in Forks Township, where he incorporates guided reflection, self-assessment, and ongoing evidence appraisal into his daily patient care. Outside of the clinic, he enjoys rock climbing, snowboarding, and playing basketball. As a few reminders, make sure that you either scan the QR code on the right side of your screen or use the code on the left side of your screen, and both of which are also in the meeting chat. If you're watching the recorded version, you're already online. Please note that the attached PDFs have been slightly updated, so the slides may be slightly different during today's presentation. Today, this is our statement of need, and it is intended for all providers. This is our designation statement, and the planners and presenters have nothing to disclose. So without further ado, I will turn it over to Dr. Purinton.
All right. Thank you, Steve. All right, let's get started. So today we're going to cover the rehabilitation process for gluteal tendon repairs, learn how to adequately progress through glute-focused exercises with the goal of returning to higher level intensity activities, and then understand the prognosis of returning to functional activities after a glute tendon repair. So just a little bit of an overview here. Lateral hip pain is a commonly seen diagnosis in physical therapy, and we as physical therapists have to determine what is the cause of that hip pain. Going through the differential diagnosis, there are a lot of different things that can be causing this, some of which include greater trochanteric pain syndrome, referral from a lumbar spine, hip osteoarthritis, and many more. And these can all be addressed with physical therapy interventions such as strengthening, stretching, and patient education, just to name a few. Typically, due to anatomy, lateral hip pain can be more common in females. So going a little bit into the bony anatomy of the hip, we have the femur, which is articulating with the acetabulum. And then there is the hemipelvis, which is made up of the ischium, ilium, and pubis. Diving a little bit deeper into the musculotendinous structures of the hip, as you can see here on the left-hand side, it shows the anterior hip musculature as well as some of the lateral and medial musculature, all of which are important for hip function. And then on the right-hand side is the posterior view of the hip muscles, and shows the gluteal muscles that are more superficial cut away, so you can see the smaller, deeper glute muscles. As this presentation is more focused on gluteal muscles, we'll dive a little bit deeper here. All of them, as you can see on the right-hand side here, the gluteus maximus is the biggest muscle of the hip, and just deep to that is the gluteus medius, and then deeper to that is the gluteus minimus. all of which attach over onto the greater trochanter of the femur. And then they all also attach onto the hemipelvis around the iliac crest and iliac fossa. Going a little bit deeper into the muscle functions of these gluteals, you have on the left-hand side the gluteus maximus, which is the main hip extensor of the hip, and it also plays a role in external rotation and abduction. On the right-hand side, you can see the gluteus medius muscle, which is a main hip abductor, and it also plays a role in internal and external rotation, depending on the anterior and posterior fibers. Another main function of this gluteus medius is to stabilize the pelvis, especially during single leg stance. The last gluteus muscle that's more superficial is the gluteus minimus, which is another hip abductor and internal rotator, as well as a pelvic stabilizer. So in this middle picture, we have a normal versus a Trendelenburg sign, which is demonstrating when a person is standing on one leg. Seeing in the normal picture, the pelvis stays stable because that gluteus medius muscle is strong. Now, when you see on the right-hand side, when you see a weak gluteus medius, that same stance limb will then cause the hip to drop on the opposite side, which is indicative of a Trendelenburg sign and weak gluteus muscles. This is especially important for functional activities that require single limb stance, such as walking or climbing stairs. There are differences also in the male versus female pelvis. On the left-hand side, you can see the male pelvis, and on the right hand, the female, which is showing wider and shallower. And this is due to the adaptations for childbirth. But this also plays a role in altering the muscle attachments, and that can change how those muscles activate and help stabilize the pelvis. So typically it requires in females that there be greater gluteal activation to help stabilize the pelvis, which plays a role into why they have more lateral hip pain typically. So diving a little bit deeper into greater trochanteric pain syndrome, which is one of those categories that falls into lateral hip pain. This is just an all-encompassing term that describes all of the structures of the lateral hip, such as the trochanteric bursa, gluteus medius and minimus tendons, and the iliotibial band, all of which are pictured on the left-hand side. Typically, this affects people in their 40s to 60s, and like I said before, is 3 times more prevalent in females than males because of the anatomy. Some characteristics for greater trochanteric pain syndrome are lateral hip pain, inability to sleep on the effective side due to the compression of the tendon on the greater trochanter, increase in symptoms with walking and stair climbing due to that increased load on the gluteal tendons in single limb stance, and inability to participate in sports and other recreational activities due to the pain and disability it causes. Now, there are different treatments for greater trochanteric pain syndrome, and the first line treatment is typically exercise and education, which is what we try to accomplish in physical therapy. Now, there is some evidence to show improvement in patient-reported function and pain using this first-line treatment, and that's really focusing on strengthening and stability of the hip itself. There are other options for treatment, such as shockwave therapy, but this is shown to not be better than exercise for pain reduction. And then there's also corticosteroid injection, which there are small studies showing exercise to be better at improving global rating of change scale versus one corticosteroid injection. And that global rating of change scale is looking at change of improvement over the course of time. One last treatment option for greater trochanteric pain syndrome is platelet-rich plasma, or PRP injection. And this is shown to be a little more effective in improving function than a corticosteroid injection. Now, the outcomes for greater trochanteric pain syndrome are not the best. Typically, patients have a poor quality of life because of the pain and disability it causes, and people with this condition are typically less likely to be employed full-time because of that. This is a chronic condition, and it can worsen and progress, unfortunately, to some degenerative tears over time at that tendinous insertion on the bone. So if there is a gluteal tendon tear, you can treat it conservatively, but there also is an option for surgical management. And there are multiple different ways to undergo this repair. The options are open or endoscopic repair, and both are shown to be effective, but endoscopic typically results in fewer postoperative complications such as re-tear. Going a little bit deeper, they can then do a double or a single row repair, but double typically maximizes that contact area between the tendon and the bone, and has shown to be superior to a single row repair. The pictures here indicate the single versus double row, and you can see how on the bottom right-hand picture, when that double row is completed, it does have a little bit more surface area covered. Now, it is surgeon preference which surgical technique they will choose, and you always want to choose the surgeon that's going to do, the one they're comfortable with, so that is up to them. There are guidelines published for a gluteal tendon repair recovery, and the one that I utilized in this presentation is the Ohio State Wexner Medical Center's hip abductor repair clinical practice guideline. And we're going to go a little bit more in depth with that, but just on the left-hand side is a summary of their recommendations. And the first 6 weeks, the big thing here is the precautions you have to pay attention to. There are weight-bearing restrictions, and then range of motion restrictions as well to not stress that repair. So no hip flexion past 90 degrees, no adduction past neutral, and no active abduction, active range of motion. So diving a little bit deeper into the protocol, phase 1 is the protection phase, and this typically begins right after post-op to when you discharge the assistive device for gait, and this is around that 0 to 6 week mark. So the goals of this phase are really to protect the tissues that are healing and to reduce pain and inflammation. You also want to encourage getting some pain-free range of motion and to normalize muscle activation. Most importantly in this stage is that neuromuscular control. You want to ensure that the correct muscles are firing without compensation for each exercise you prescribe, because that will carry over into better strengthening down the line. So the first few weeks, exercises can focus on non-weight-bearing strengthening of the hamstrings, quads, and hip abductors to further strengthen that hip-core relationship, and then progress to more weight-bearing activities as long as there's no additional pain or swelling. Around 4 weeks, you can add submaximal hip abduction isometrics in a neutral position as to not stress that tendon. So other ideas you can include here are some passive hip range of motion, gentle quad stretching, double leg bridges, and initiation of a stationary bike. Now, there are criteria to progress to phase 2 of the rehabilitation protocol. What we look for here is normalized gait with an assisted device, so not having any compensations with pelvic drop. Having minimal to no reactive pain with physical therapy exercises or their activities of daily living, and then ensuring that there is good muscle activation. It's isolated to specific muscles. Picture here on the right-hand side is the prone hip extension test, which is another indicator to use to progress on to the next phase. You want to look at symmetry of sides and looking for at least 10 repetitions on that surgical limb to pass on to the next phase. Phase 2 is going from when you discharge the assisted device to pain-free activities of daily living, and this is typically from that 6 to 12 week mark. Goals in this stage are to progress motion of the hip to full, actively and passively, and then improve that proximal hip musculature to normalize lumbopelvic control with all double leg and single leg activities. You also want to ensure that patients are able to walk the distance without an assisted device that they were typically used to before, and can tolerate all of those activities of daily living without pain or limitation. In this phase, we kind of shift to a more functional base strengthening program to focus on squatting and other activities requiring single leg stance. And you can also progress the hip abduction strengthening, which is really important to work through that active range of motion that you now have. Some other intervention ideas here include forward step-ups, four-way hip in standing, and single leg balance. Criteria to progress to phase 3 of the protocol is to have symmetrical and pain-free hip range of motion that's specifically meeting what the patient needs to get back to. You're looking at a double leg squat and seeing if they can get at least 70 degrees of knee flexion. And pictured here on the left is the active hip abduction test. Again, looking at symmetry of sides, but also hoping to get that 10 repetition for the involved limb. And then the picture on the right is the step down test, at which you're looking for 10 good repetitions from an 8-inch height with good neuromuscular control and no pelvic drop. You also want to ensure that the patient is able to walk those community distances with a good gait pattern and without any compensation. If they meet those, they can move on to phase 3. And this stage is encompassing from when they complete their ADLs pain-free and then they're trying to return to their prior level of function. And this occurs at that 12-week mark and beyond. The goals here are really to gradually increase and progress that strengthening and stability of the hip and correct for those compensatory movement patterns, especially with functional tasks. Trying to improve balance in this stage and then increase the volume and intensity of activities that they're trying to get back to. If they are returning to work, you want to ensure that they're able to do the demands of that job without hip pain or limitation. In this phase, it's really more sport specific or return to work specific, whatever that patient needs to get back to, as well as continuing to progress the strengthening of the hip, lateral hip musculature. So when we're determining if they're ready to return to sport or if they're ready just to discharge, we really want to look at strength, the limb symmetry index with strength, and that can be used as a hip handheld dynamometer or strength using a single leg press or an isokinetic machine if that is available to you. You're really looking at least 90% limb symmetry index comparing the involved and uninvolved leg. If they're returning to hopping or sport that requires hopping, you can also look at hop testing and their ability to complete those sport-specific tasks as needed. You can also look at the hip outcome survey as an outcome measure and see if they're reaching that 90% or higher for the sport subscale as well as the activity of daily living subscale. Phase 4 is really at 16 weeks and beyond when they're really returning to sport at full capacity. They're able to initiate the running program as shown here on the right-hand side. And typically for a patient to return progressively, it takes about 6 months to get them fully back to where they were before after the surgery. In this phase, it's really important to continue progressing, but limit if they're having pain. You don't want to progress through pain. And then also emphasizing proper landing mechanics, both with double leg and single leg activities. Again, here doing more sport-specific training and exercises to kind of mimic what they need to get back to. So here's a summary of those guidelines for each phase, just to kind of quickly look at and see what is important to pass testing-wise to move on to the next stage. So my question next is, what does the research say about functional outcomes after gluteal tendon repair? Well, there is some research that does exist on this topic, but it is very limited, especially when they're looking at returning to functional activities. So that's why I kind of dove into this topic. There is a small body of evidence looking at gait, comparing healthy individuals to those post-gluteal tendon repair. And those individuals, after having that repair, typically demonstrate slower gait speed and reduced stride length around that 6-year post-operative mark. They show that continued gait dysfunction can be a sign of incomplete rehab and possibly needing more strengthening and control, or a subsequent repair failure. There's another study that looked at the sit-to-stand tasks of a couple people post-gluteal tendon repair versus healthy controls, and they found that those after having that repair done demonstrated decreased rate of force development during this task around that 6-year post-operative mark. There was one study that looked at patients after gluteal tendon repair returning to activity and exercise. And around 2 years, 68% of patients over the age of 50 were able to return to their activity of choice, either at the same intensity level or higher than that of their previous level of function. The chart here on the right-hand side shows the different activities that those patients in the study were returning to, and the percentage of those that actually returned. And the highest, most common ones were bicycling, walking, and golf. And so it shows that a good percentage of patients are actually able to return to what they would want to get back to. Now, as for stairs and single leg stance, these are also important functions in our daily life, but there's not any published literature out there about these tasks after a gluteal tendon repair. So this brings me to a patient case. I had a 59-year-old female, status post right gluteus medius and minimus tendon repair, and this was completed with open double row in September of 2025. This patient had a long history of chronic lateral hip pain for about a year, and she had minimal relief with a corticosteroid injection. Previously, she had extreme pain with all activities, even sitting and sleeping. And she then, in July of 2025, felt a pop in her hip when she was completing a hip external rotation stretch. And the MRI showed a full thickness tear, which is shown on the left-hand side here. You can see how the gluteus medius tendon is kind of off of the greater trochanter. Previously, she was very active, attended the gym daily, and completed the stair climber 45 minutes, 5 days a week, and participated in lower body strengthening. So she presented to me after the surgery, 2 weeks out, and she had pain with weight bearing and passive hip motion, limited strength and gait and stair climbing ability. And she was using bilateral axillary crutches and had this hip spica brace, which is shown on the right. The precautions here were she had to wear that for 6 weeks whenever out of bed. And she had already gotten past the point of being toe touch weight bearing and was now 50% partial weight bearing. And then we had those precautions of no hip active range of motion of the abductors and not going beyond neutral and 90 degrees of flexion. So this table details different time points throughout the physical therapy recovery of all of her functional outcomes. So the initial eval, it shows 2 weeks after her surgery, and then discharge was 20 weeks post-op. At this point, the patient wanted to return to just home strengthening program. She felt confident that she had met her goals, and I felt that she would be able to continue at home as well. So as time progressed, looking at gait, she did have some compensations early on, and then even towards the end at discharge, she demonstrated pelvic drop when she was more fatigued. Now, it is typical to have some pelvic drop, but not more than 5 centimeters with walking, and she had a little bit more than that when she was more fatigued. As for the sit-to-stand test, very early on, she was able to demonstrate good force output and good control, and she kind of met that metric there. As for step-ups, she did demonstrate compensations going into 4 months into rehab, but then she eventually was able to complete a high box step-up without any compensations. As for lateral step-downs, she was never actually able to complete that high step down with good control as determined by the protocol. She was able to do a lower height, and she didn't have any pain, but she definitely was not able to complete that higher step down without any pelvic drop. So that was one of the things we were really working on. As for single leg stance, she was able to complete that by the end of physical therapy with symmetrical time. And her strength was a little bit limited on that surgical limb. But she was able to return to the stair climber for 30 minutes by discharge and only had typical muscle soreness with that. So kind of breaking down a little bit into how she completed these functional tasks versus a healthy individual. By discharge, her gait was a little impaired compared to a healthy individual just due to that fact she had pelvic drop. when she was more fatigued. And I think that could be because of a number of reasons, potentially fatigue impacting that ability to maintain the normal hip pattern, or potentially from a learned gait pattern that she had developed for some time before surgery because of the pain she had previously. As for a sit-to-stand, she had met the age-match norms, had good control and power, and based on that one study that demonstrated those people after glute tendon repair have less power, she actually was pretty equivalent to a healthy individual, which was good to see. As for single leg stance, like I said before, she was able to complete that symmetrically on both sides without pain or compensation, which I would categorize as equivalent to a healthy individual. And then as for step ups, able to complete without pain and hip drop, and able to complete that 30 minutes on the stair climber, which is what her main goal was, which is indicative of equivalent to a healthy individual. And then step downs. We discussed previously that she was unable to complete a high step down without hip drop, but could from a lower step. But this is too impaired compared to a healthy control. So although compensatory movement patterns persisted in this patient, likely related to residual strength and endurance deficits and potentially learned motor patterns due to preoperative pain, the patient successfully returned to her prior level of function and achieved her goals of using the stair climber and getting back to lower body strengthening. Some of the key takeaways here are that patients can have significant pain reduction and improvement in functional mobility after rehab following gluteal tendon repair, but they can have compensatory movement patterns persisting 20 weeks after that repair, especially with functional tasks requiring single leg stance. It's also a good takeaway that patients after this surgery can return to their activity of choice at a higher level or the same as their previous level of function, which is important to know for us as physical therapists trying to get patients back to that level. And the last thing that's the main takeaway is it's important to educate these patients that they should continue hip strengthening program even after they finish physical therapy so they can have long-term success. I think my patient case scenario, if she were to continue strengthening as I educated her to do, I think she can then eventually complete that step down without the hip drop. But this is the big takeaway, is to make sure you're telling your patients strengthening is important and to keep doing that to maintain their functional mobility. And those are my references. So
if you have any questions, feel free to unmute yourself and ask, or if you want to type it into the chat, you may go for it. One question I have while we're there, you mentioned about the step down from an 8-inch step. Mm-hmm. I'm definitely biased because most of my patients come to me with problems. However, even on their good side, a lot of them have difficulty with an 8-inch step down or even a 6-inch step down with maintaining control. There's a lot of literature arguing that return to play for upper extremity protocols are too stringent, and there's arguments that is that really necessary? And I question, similar to this, on the flip side, I also question, is that necessary to prevent future injury, and is that why they are so stringent? So that's kind of a double question to you.
Yeah, I agree. And you can see that even though we progressed past that phase 2, which required that you meet the 8-inch anterior step down, she wasn't able to do that with good control. But I used my clinical decision making to determine that she wasn't having pain with that task. She wasn't at that point the tissues were healed, and I didn't think what she needed to get back to, it was necessary to restrict moving on to the next phase to further strengthening without meeting that step. So I think that's why I kind of moved on, and I do think it is important to keep strengthening to ensure there's no more injury down the line.
Cool. Thank you.
Yep. All right, I'm gonna move on to Joey.
Thank you again, Megan. That was an excellent case. And I think it's going to go into my next topic here on reflective practice. Here are my learning objectives. essentially, we're going to sort of reframe the reflective process to what you may already assume about reflection and offer some strategies to integrate this into your clinical practice. So the reason I chose this topic is because the residency has been such a fruitful experience, but the reality of it is that it's coming to an end. I'm not going to have rigorous coursework after June 29th, and how am I going to continue to grow? The biggest skill set I feel like I've got here from the residency is being able to reflect. So I just pose the reality that as any healthcare provider, we all have to synthesize and decision make on a regular basis. And a lot of research has shown that reflection and learning are really linked. With that said, that transition to clinical practice is still kind of vague. So with today's talk, I want to reframe that. So before I get into the nitty-gritty here, I want to just pose you, the listener, how do you view reflection? Do you view it as your drive home from work, just kind of thinking about things, or the typical reflection journal you may do? I'm here to sort of change that perception. So in my first slide, we see that reflection is a cyclical process. And when it's clinically oriented, it's triggered by an atypical case, a state of doubt, uncertainty, and proactively thinking what we can do in the future that could be better. So just from the start, reflective inquiry starts with the definition of clinical reasoning. And as providers, it's important that we recognize our diagnostic power is dependent upon this metacognitive ability to think about what we're thinking. Cobb's learning cycle is a great model to sort of visualize this process. If you point your attention to the top right, it starts with the experience itself, and most often neglected is that reflective observation, which leads to learning, and then experimenting forward. I kind of love how in the residency I've been exposed to the philosophy of test, retest, and how it took a while to really grasp the art of doing that with a patient in front of you. But I like how when the active experimentation here in the model, you do it with your own clinical reasoning, that reflection for action. So the key element here is that you're scrutinizing your own grounds for explaining problems and the decisions you make to solve those problems. So add a little history in here. We have two individuals for this, the metacognition research. They stand upon their shoulders. John Dewey was the pioneer of experiential learning. And Donald Sean, there's a new last on that O, couldn't figure that out on the keyboard type, but these are great quotes that really symbolize the power of reflection. Next, I'll get into the timing of reflection. Most of us as clinicians visualize the blue bubble here. This is that reflection after the encounter. This is thinking about it, writing about it, and talking about it with a mentor. It's important, it serves its place, but there's other times of reflection, and expanding out into those domains are great. I really love this visual because it superimposes Cobb's learning cycle on the timing of reflection. And I don't expect you to look at this and parse how you're going to reflect in specific ways, but fully appreciating this is the first step. So this is a good tabulation for understanding the true difference between practitioners who are able to reflect in and on action. I'm more sports-minded as an individual, so my brain goes to timeouts in a game of like basketball or any other sport. I mean, what do timeouts serve? They allow the individual or team to remove themselves from the experience to deliberately review and talk about changing things. But the real power is when you can make those changes on the fly. Point your attention to who does it best. These are the experienced and autonomous providers. They can reframe and continually evolve their hypothesis list to better treat the patient in front of them. This happens during the encounter, and it happens unconsciously. So the strategies I'll talk about today necessarily won't directly change that, but the better we can do it passively, the more we can do it tacitly in the encounter. So with that said, as I alluded to, reflection is difficult. There's ambiguity between implementing theory and practice. And coming from the residency, that's not my case, but as I observe basic culture in healthcare, as I ask people, they don't typically like reflection, but I've really grown to hold on to it. So I want to talk about some ways we can sort of better understand the components of reflective practice so we can come up with more in-depth exercises to reflect more profoundly. What are these 5 skills? There are 5, as I said. How self-aware can you be? Can you recall specific events from a case, the emotions, your decision-making? What were you thinking? What were the specific details of that patient's history? That ability to retrieve the information specifically is profound. The memory, the autobiographical memory. You ever read a good memoir or autobiography, it's amazing how well they can recall those things. And I just realized I said self-awareness was autobiography, but that's all right. Third, perspective taking. How well can you view things from another perspective? Metacognition, viewing things from actually thinking about your clinical reasoning, and then the cyclic process that every time you go through it, it's going to build and get better each time. Here's a good developmental model that pretty much symbolizes it depends when you ask a question in any kind of a scenario. Recognizing that it depends shifts you from the stage 1 and 2 down to the 4 and 5 kind of spectrum of reflection depth. To basically encapsulate this table, asking what is the correct answer is kind of your upper stage, and then your more profound reflective capacity here is, how do I know that the reasoning I'm using to explain my right answer is sound, and how can I disprove what I'm saying? This allows for more evidencing integrated reflection and less absolute truths to more gray truths, which is the clinical reality we live in. So here are I'm going to go into some reflective exercises for each one of these components to take home for you guys. A simple self-awareness skill is just stopping. The stop method, it can be used in transition points in your clinical day, whether if you're en route to grab a patient for an eval or throwing away linens or on your lunch break, the ability to kind of halt that autonomic or reflexive process and give you the chance to start their reflection is key. It's the first step, and doing that more oftenly is going to be huge. Specificity is key. If we want to improve our autobiographical memory, we're going to have to do just that. But how we do it is key. It doesn't have to be a journal. It doesn't have to be by your bedside at night. It could be with your colleagues. It could be mentally. Continually rebuilding clinical cases and organizing them and making them coherent in that narration is its own skill set. And doing it, practicing that is the only way to get better at reflection. This is an interesting exercise about Valtonen et al. This year, actually. This is 3 perspective writing. You write a clinical experience from the perspective of yourself. Then you write it from the assumed lived patient's experience, voice, and role. How well can you put yourself in their shoes? And then 3rd person perspective here is a neutral observer outside the interaction. Another great thing we do in the residencies, as much as I hate it, we have to do these filmed clinical evaluations. Patients consent to it, and we have to take that 3rd person perspective here. Now, in your clinical practice, you might not be doing that on your own volition, but mentally exercising that is going to improve that empathetic flexibility. So probably the most clinically translation slide here is that metacognition. Reflective practitioners are going to be going back to problems or situations they found to be difficult. How they do that's key. This protocol provided by Mamede and Schmidt is essentially a differential diagnosis list, but it goes a step further in that you have to think about and identify the findings that were in favor of that hypothesis you had generated, things against, and then more importantly, that 3rd column there is findings expected to be present but not described. As clinicians, we love to satisfy clusters and likelihood ratios, but we often can have a framing bias with things, and that row or that column is a good metacognition skill. set iterative processing. Iterative is just a fancy word I use to sound educated. It means cyclic, repetitive. Driving, we drive all the time. We don't have to reflect when we drive because we do it so often. When it comes to clinical practice, it's a little more nuanced. Every time we go through this process, it's going to get better and better. And alluding back to that reflection spectrum, we'll get more and more deeper with that reflection. But with that said, it's not done alone. It's enabled through feedback. Ongoing mentoring normalizes this reflective practice, and it doesn't have to be a set-aside mentor. Utilizing your colleagues is a good resource for this. And as your conversation's improving, asking different questions, this is going to allow you to audit that iterative processing skill. To kind of encapsulate all those skills in the one simple model here is a what, so what, now what model. It's basically describing all those events using that autobiographical memory, analyzing it, why did it matter, and now applying it. Reflection for action. So with all that said, I kind of want to tie it all together. It's all kind of abstract stuff. Let's tie it into a case that I adapted here, very similar to a patient I had seen just a couple weeks ago with a mentor I had with me that morning. So the patient had bilateral shoulder pain and a significant past medical history of social instability. There was just a lot going on. And he had been using the emergency department for pretty much all of his needs. He had a lot of visits at the ER just to fulfill medication refills. And it turns out that the Invega shot, which is used for mood stabilization essentially, he's been injecting that into his deltoid region every other 2 weeks for years. And he had recently just translated from that injection therapy to an oral. And now coming in to see me in therapy, he wanted to address his shoulder pain and basically be able to lift his arm up higher. So with that history, I had kind of a differential list kind of narrowed down to injection site related shoulder pain. I mean, it temporally and locationally matched the history. And on physical exam, not super tender on the deltoid, but he had limited active range of motion. And to be quite honest with you, I just didn't dive deep into it. So after that, I pretty much came up with a subacromial pain diagnosis. He doesn't move his arm much. He's very sedentary. So that was my competing list. Now, luckily, I had my mentor there, and he was able to help reflect on that action so profoundly. He helped me reflect on how this patient had met a lot of criteria for adhesive capsulitis. And I'll kind of transition to my next slide here. The deliberate reflection protocol that I had showed before, I'm just adapted it for this case. Basically, I initially had a subacromial pain disuse, muscle disuse pathology for this patient. But then we had reviewed some articles. The STAR shoulder model is a good resource we use to kind of help sub-treatment categorization. But my point here is that I missed two big things here at the bottom. He had met criteria for thyroid disease and diabetes and nocturnal pain and insidious onset. And not that he had the capsular pattern there. He really didn't present as a frozen shoulder, but I didn't have it on my list. So I raised this case example to sort of show as my example, I failed to kind of have the most robust list for the patient, and going forward, how I will be different and provide a more competing diagnosis list for shoulder pain, especially when they have these flags for other signs. So, in conclusion, I hope I've introduced another view on reflection, that it's not done alone and it's not done with journaling, and that it's really done collaboratively and it can be done in practice. A few micro-reflective habits that I'd like you to ponder here is the pre-encounter pause, the diagnostic pause. Before you dive into something, maybe take a second, give yourself a little time out in your clinical day to ponder what you're doing. practice your narration and welcome as much feedback as possible, as that has been shown to improve the quality of reflection. So with that said, I'd like you to reflect on your reflection. Thank you for your time.
All right, so what questions do you guys have? Please feel free to unmute yourself or type into the chat.
Joey, I have a question.
Yeah.
So you recently had a student, I know that, right? And were you able to, this is a two-part question. Were you able to utilize some of those strategies to get your student to practice those reflective behaviors? And if so, how did you do it?
It's a great question. And to be honest with you, it was both ways. She had actually helped me produce this topic by helping me reflect. And yeah, I feel like the best way I helped implement reflection into her student rotation was just hypothetical questions on how different scenarios could go. And I feel like the debrief is a powerful tool after an eval or after the end of a long day, just using that debrief time to just talk about whatever was atypical or challenging moments. Thank you.
Thank you.
What other questions do you guys have? Somebody's typing in. Did you or your student find her weekly reflection assignment helpful?
It got the conversation.
Did you complete it on paper or on Copilot? All right.
It's a great question. I find that the Copilot function to be quintessential for facilitating those thoughts. But yeah, I think it was very helpful. It got the conversation going. We only had to do it for the first 4 weeks, and then we opted not to do it because we had our own patterns. But yeah, I think it was great.
So just for the listeners, can you explain what the Copilot reflective project was? So just so that people can understand that, especially if they're not clinical instructors or not in this network.
Yeah, can you reframe the question, the Copilot project?
The Copilot reflection assignment.
Oh, gotcha. Yeah, so I would even just go as far as to say it was amorphous, not a specific assignment, but using, just difficult moments and then taking that thought process and then asking the Copilot to offer other competing theories, using that deliberate induction reasoning, basically just assistance for that process, and using that Copilot feature that we have as St. Luke's providers to your advantage.
And Copilot is a generative AI.
Bingo.
Okay, awesome. Thank you.
Thank you.
You said, thanks, Joey. Great job. All right, what other questions do you guys have? How do you feel that you use reflective practice the best on a day-to-day basis? In a busy clinic, it's not like you can just block out hours at a time. How do you personally do it best?
Well, unfortunately, the residency blocks out hours for me.
But in a real life practice, how would you recommend that we implement this on a daily basis?
Great question. And alluding to that wrap-up slide, I think becoming more self-aware and using those transition points to kind of just pause and scan what your thoughts are and scan what your biases may be, and pretty much guiding that reflective process with the challenging moments of the day. Whatever is on your mind, maybe over the weekend, a typical case or not the right outcome. I think it's unavoidable to have some work outside of the practice, but yeah, I think that self-assessment skill is huge.
Do you ever reflect on the drive home?
All the time.
Thanks. Thank you.
You're welcome.
And with that, if you have any further questions, please feel free to reach out to either me, Dr. White, or Dr. Purinton, and we would be happy to respond to you. Make sure that you complete both your quiz and your course evaluation, and we will see you next time for Rehabilitation Movement Science Grand Rounds.